Thank you for logging on to today's webinar. We're going to be getting started in about 2 minutes. Thank you for logging on to today's webinar, How to Implement SBIRT Processes, Tips, and Examples from the Field. We're going to be beginning in about 1 minute. Thank you for joining us today for today's webinar, How to Implement SBIRT Processes, Tips, and Examples from the Field. We're going to be beginning momentarily. Thank you for joining us today. I'd like to welcome you all to today's webinar, How to Implement SBIRT Processes, Tips, and Examples from the Field, featuring Megan O'Grady. At this time, I'd like to go over a few housekeeping items for today's webinar. We'd like to encourage you all to participate in today's webinar via 3 methods. First, if you have questions for today's speaker or are experiencing any technical issues, please use either the chat box or the questions pane to communicate your questions. Periodically throughout the presentation, we will stop and ask for questions, at which time I will read aloud any questions that have been submitted. Again, you can submit questions via the comment or questions box. Throughout the webinar, all participants will be on mute. If for any reason you would like to be unmuted, please click the Raise Your Hand request and unmute your personal phone or mic. I, as the organizer, will unmute you to speak directly onto the webinar. You're also able to collapse and expand the GoToWebinar panel via the arrow button should you choose. 1 hour following the webinar, you're going to receive evaluation and continuing education request information. This webinar is approved for 1.5 PCB and 1.5 NADAC credits. You can also request a general certificate of attendance. I'll go over all of this again at the conclusion of today's webinar. Now at this time, I'd like to go through some poll questions. We'd like to get a picture of the demographics and SBIRT experience of the audience. These questions will appear to you on your screen as an interactive poll. Please select the best answer as it applies to you. Our first question is, what is your current professional role? Are you a counselor, therapist, or social worker? Or case manager? Are you a nurse, nurse practitioner, physician, or physician assistant? A program or unit administrator? A university student or faculty? Or other? Okay, great. Thank you. I want to thank everyone for participating in that poll, and I'm going to go ahead and share those results with you. So it looks like the majority of our audience is either a counselor, therapist, social worker, or case manager at 36%. Our second highest is other. Now, if you listed other, please feel free to share with us what professional role you are in via the questions box or the chat box. We'd be happy to share that with today's presenter. We also have 20% of the audience as a program or unit administrator. For our second question, which field do you represent? Are you in mental health, addictions, physical health, education, or EAP? Okay, great. Again, I want to thank everyone for their participation. I'm going to go ahead and share those results with you. It looks like the majority of our audience does work within the addictions field at 40%. Our second highest is the mental health field at 33%, and 20% at education. Now, if none of those fields apply to you, again, feel free to share with us what field you represent in the questions box or the chat box. You can see one person has responded and said that they work as faculty and a practitioner. For our third question, do you conduct SBIRT interventions? Okay, great. Again, I want to thank everybody for participating in that poll. Looks like the majority of our audience does not currently conduct SBIRT interventions at 74%. And for our last question, do you see your agency using SBIRT? Okay, great. I want to thank everyone again for participating. I'm going to go ahead and share those results with you. And 87% of our audience has selected yes, they do see their agency using SBIRT. I also want to read off one other profession that's come in, a medical director of a Medicaid CHIP health plan. Now at this time, I'd like to introduce today's speaker to you. Megan O'Grady is the Associate Director of Health Services Research and a research scientist at the National Center on Addiction and Substance Abuse. She is an applied social psychologist who focuses on the integration of care for physical and behavioral health problems. Her recent work aims to understand how implementation of screening and brief intervention is best accomplished. Now, Megan, if you are ready, I'm going to go ahead and unmute you, and I can make you the presenter. Just let me know when you get that presentation request. And can you give us a shout? I just want to make sure your audio is working.
Okay, can you hear me?
Yep, that sounds great.
Okay, great. Thanks so much, Sarah. Thanks so much to IRETA for having me. I'm very happy to be here today to discuss the implementation of SBIRT. I've worked over the past 5 or so years on various SBIRT projects, and I'm hoping today to share some practical and useful tools and tips for folks who are interested in implementing SBIRT or who might be in the process of doing that. So hopefully today we'll provide you with some practical things to think about as you're going through that process. So before I get started, I wanted to acknowledge my current and past collaborators and funders. So the team here at CASA, the National Center on Addiction and Substance Abuse, we have a large team here that focuses on SBIRT. Our current collaborators, Northwell Health and the New York State Office of Alcoholism and Substance Abuse, we have currently the 3 organizations are partners on a SAMHSA SBIRT grant, and so we'll be talking and giving examples from that project, and then I've also worked in the past with Montefiore Health and the New York State Health Foundation as funders. So a quick overview of what I'm going to be covering in the next hour or so. I'm going to do a quick review of some SBIRT basics and then discuss some barriers and facilitators of implementation, some practical implementation tools, tips, and examples. We'll talk about how to put it all together and then other practical things to think about. And then towards the end, one of my colleagues from Northwell Health, who's part of the SAMHSA-funded SBIRT project, will come on and give us his top 5 tips from the field that he's learned over the past couple years in implementing SBIRT in the Northwell Health system. So I'm just going to give a very basic overview about what SBIRT is. For those of you who are interested in a very detailed description and review of all the components of SBIRT and more of the clinical side of things, there are a lot of resources out there. I won't be talking about that today, but I'm happy to direct you toward resources if that's something that you're interested in. So just a quick review, SBIRT is a structured approach that's used in a variety of settings, so healthcare settings, mental health, school-based settings, EAP settings. And the goal is to really identify folks who may be at risk due to substance use and provide intervention to them. And for those who may be at risk for substance use disorder or who may need to be assessed further to see if they have a substance use disorder, to provide a linkage to care for specialty treatment for those people. Breaking down the steps a little bit further, the S of SBIRT is screening. And so the idea here is to quickly assess the severity of substance use with a validated tool. There are lots of tools out there, and for different populations, the audit and the DAST and the assist are examples of some widely used validated tools. And the idea here is to identify the appropriate level of intervention for the people that you're screening. Some people break up the screening process into 2 levels, where a very brief few question screen is done, and then a longer screening is done only for those who qualify. And this can help with the workflow a little bit, in that you don't have to spend as much time determining level of risk if you do a pre-screen full screen. Typically, screening just takes a few minutes, and then you can identify whether someone needs a brief intervention and what level of risk they are. Once you get to the brief intervention, the idea is to provide feedback to the person about the level of risk that they're at based on what you learned during the screening, trying to increase insight and awareness regarding their substance use and hopefully increase their motivation to change if they are at risk, and then negotiate and set goals. There are a lot of different models of doing brief interventions out there. So there isn't just one, but these are sort of the general things that are covered under most models of brief intervention. And then finally, for a small percentage of people, you may need to make that linkage to care, so that referral to treatment. This is typically a very small percentage of all of the people that are screened, but that percentage is going to vary based on what the setting that you're working in is. For example, an emergency department might have a much higher level of severity patient than a primary care practice. Or a mental health care setting might have a higher level of severity. So that, the need for referral to treatment is going to vary based on the setting and the population that you're working with. So that all sounds nice and easy. There's a nice acronym, SBIRT. SBIRT has been around for quite a long time in the field. Unfortunately, what we've seen is that large-scale implementation and maintenance of SBIRT as a practice in healthcare settings has really been limited, despite some evidence for effectiveness in reducing substance use or related consequences in certain contexts and circumstances, as well as a great deal of government and policy organizations promoting widespread adoption of this practice. For example, SAMHSA has been funding for 10 to 15 years now states to implement SBIRT in healthcare settings. The United States Preventative Service Task Force has rated alcohol screening and brief intervention as a B, so they recommend that it be completed, and several other organizations. So what are the barriers and facilitators that are keeping this from becoming a standard in healthcare practice? And I'll stop there and say that, in the poll, I could see that a lot of people are working in addictions and mental health settings. And while a lot of the examples that I'll provide today are from the healthcare settings, because those are the settings that I'm most familiar with, the processes, tips, examples, I think can really apply in most cases to any setting in which you're trying to implement a new practice. So don't let that deter you if you're not working in a healthcare, emergency department, primary care, or other kind of physical healthcare setting. Now, barriers and facilitators of SBIRT implementation can really occur at a lot of different levels within the system. And there has been a lot of work to identify what these specific barriers are when you're trying to implement SBIRT. And we know from the implementation science literature that these barriers and facilitators really can affect the success of intervention implementation. And we also know from this literature that more intensive efforts to address these barriers during implementation tend to be more successful, which makes sense. The more effort you're putting in, the more intensive effort, the more success you might see. So looking a little bit more at some of these barriers and facilitators, so if you think about at the staff level, if this is a setting where alcohol, drugs have not typically been addressed before, staff may not feel it's their role to address alcohol or drugs. They typically might not have received any training in how to address that and may not feel that they have the skill to do so. So, if this is a barrier, you might want to focus heavily on training and skill development for staff. At the patient level, a lot of people fear that patients will be very resistant or reluctant to discuss their alcohol and drug use. And what we found in our practice, as well as other folks out there who have done this, is that very often people are not reluctant to discuss. You will have some people who might be a little puzzled about why this is being asked, but typically what we've experienced is that this isn't a major issue. You might have to adapt the implementation of SBIRT based on your patient characteristics. So for example, depending on the main language spoken within that practice, or the main cultural population that you have, attention might need to be paid to what the patient characteristics are, so that you're making sure you're implementing SBIRT in a way that's going to be applicable to that population.
Megan, before you move on, I'd just like to share a comment from one of our attendees.
Okay, great.
They shared that the #1 barrier they've found is that they found the provider's report is time.
Yep. I think that's one that comes up quite a lot. So, people say that they don't have time, and if you see under the site bullet point here, competing demands, whether it's at the staff level or at the site level, depending on how you're implementing SBIRT, time and competing demands are something that we've commonly seen in sites that we've gone into. So absolutely, thank you to that attendee for mentioning that. At the organizational level, it's very important to have support for this practice and resources, if any, to implement. So whether it's resources and extra staff, or at least release time for staff to receive training and buy-in from the organization. At the site level, it's very important to understand what the workflow is and understand what the competing demands are. So, when we've gone into sites at the same time, there have been other initiatives going on that are really important too. So, in one site we went into, there was a hepatitis screening initiative that was going on. In an emergency department we were getting ready to implement in, they were also receiving their trauma certification, and so a lot of the staff training was being focused on, learning about trauma. And so there are always, no matter what site or setting or kind of place that you're going in to implement SBIRT, there are always going to be competing demands and lack of time. And so really being flexible and rolling with that and understanding how you can build this practice into the workflow so that you don't negatively affect the workflow is very important. Another thing that comes up a lot for us is space. So this is especially important if you're adding an additional staff person, or even if you're using existing staff, if they need a space to go to speak with a patient that is private, space can be an issue as well. At the state, federal policy level, there are a lot of different things that can be going on. Some things can be good. So I think there's a climate going on with the Affordable Care Act and a lot of reforms that are going on that can actually facilitate getting behavioral health practices into healthcare settings and integrate care. But on the other side, there are things like privacy rules that limit exchange of information, so that if you're trying to make a referral with a specialty practitioner, or you're trying to exchange information back and forth between, let's say, a primary care practitioner and a specialty treatment provider, you need to make sure you're following all the privacy rules and have the proper releases. A lot of people are trying to work with health information exchange and do this electronically, and so there are a lot of policies that restrict that at this point. Billing is also an important part if you're hoping to gain some revenue as part of this practice. There are different states have allowed Medicaid billing, so that kind of varies at the state level as well. So a lot of things that could either impede your implementation or actually facilitate it. So it's not all doom and gloom. I think there are some solutions that you can use when you're thinking about implementing SBIRT that can really help to make this a more strategic process and really help to gain buy-in and feedback from other staff. So I think understanding what the barriers and facilitators are before you try to implement and not hearing about them while you're trying to implement is very important, and really understanding the workflow so that you can actually tailor your strategy rather than have to play catch up if you haven't learned about those things before you're trying to implement. So really understanding before you walk in the door and expect to start doing SBIRT, what these things are. And the other is that we can borrow tools from sort of the business world and from quality improvement methods. So the improvement guide is sort of the Bible in quality improvement methods, and we can borrow some of those processes. So really emphasizing systems change rather than focusing on an individual, utilizing champions and change teams, using data to understand the process, and using quick, rapid change processes. We're going to talk about all of these things in more detail as we go through the next hour. So before we get to those specific tools, I just want everyone to be thinking about the many decisions that need to be made as SBIRT is being implemented. So each piece of the process really has decisions that need to be made along the way. And using the tools that we're going to talk about, you can start to think about how these things might work. So for example, for the screening piece of it, who's going to perform it? At what frequency might you perform it? Would you do it every time a patient or a client walks in the door? Or would you do it maybe annually? What tools would you use? And what is your protocol going to be? I think I mentioned protocol in all of these, and I would just emphasize that it's important to come up with a very clear protocol for every piece of this once you've made your decisions. Similarly with brief intervention and referral to treatment, who's going to perform that? What's the protocol around that? Deciding if you're going to bill and how you might document that, and even understanding whether the systems are in place that need to be there for you to be able to bill. The performance monitoring and evaluation piece, so this is about data. How are you going to know how SBIRT is working, what data items might you want to collect and who's going to do that? How are you going to inform all staff of this new initiative, and how are you going to train staff? So lots of decisions to be made, but I think kind of the great thing about SBIRT is that it is an adaptable intervention. A lot of different people can perform SBIRT if they are trained. It doesn't need to be someone with an advanced degree. So that's one great thing. The other is that you can break up this process. The same person doesn't need to do the screening, brief intervention, or referral. You can really break it up and make it a more team-based model. And that really gets around what one of our attendees has mentioned, which is time. So if you've got a lot of people who don't have a lot of time, can you think of a way to implement this so not one person has to spend a lot of time doing any one of these pieces? So here are the 5 tools and processes I'm going to be talking about, and we'll start with champions and change teams. So to get started when you're implementing, it's great to have somebody who's really going to lead that process. So someone who's going to take a special interest in action in implementing SBIRT, who's going to really promote the benefits of it and really help to change the norms at the site. So there might be people who aren't on board at first, and this person can really help to start changing the minds and the way people think about this. The champion should really be someone who understands the site, is working, should definitely be working at the site, but also really understands the clinical workflow of the site, and is going to be supportive of SBIRT implementation. It really helps if someone is well respected by their leadership or peers, because if someone who's not respected, comes to everybody and says, hey, I want to do this, and they're not well respected, it's probably not going to work out very well. And you really, because you need to be flexible and open-minded in how you're implementing this, it's great to have someone who's enthusiastic, a problem solver, and can be flexible and work with others to really make this work. One other note is it's really great if the person is not necessarily a supervisory staff or part of the leadership at the site. It definitely helps to have them as part of the process, and you do need them as part of the process, but if it's someone who really is working on the front lines rather than supervisory, that's going to help out a lot. Okay. And I will go, let me go back. I should mention that I've put a screenshot here of the SBIRT implementation manual that my organization, CASA, had created. We created this a couple years ago, so there was a team of folks here that worked on it. It's available on our website. I've put a link to it on the last or towards the end of this presentation. And all of these steps and also worksheets that help you work through these steps are included in this manual. So we welcome people to use that, and we hope it's helpful. Okay, so moving on. So what would the champion's responsibilities be? So in our experience, again, it needs to be someone who speaks enthusiastically about SBIRT and that can really, take on a leadership role, even if they're not, a part of the supervisory team. You want them, if they're going to be someone who's actually conducting a piece of the SBIRT process, that they're actually a good model for doing that, so that other people can see how what the best practice is. And you want someone who can really get feedback and heighten the morale of staff. They can address questions, concerns, and help assist in quality improvement cycles. It also helps if that person, the champion that you're choosing, is not necessarily, so it helps if they actually volunteer once they understand what the process is and what the program is, rather than just being selected by supervisory staff. And that's because you want someone who's really going to be interested rather than assigned this as a task. Now, when you're thinking about a change team who's really going to come together to make this implementation work, you want a group of individuals with knowledge about the site. Again, so they should be people who are working at the site, who have intimate knowledge of it, and it could really be a broad spectrum of employee, all the way from the administrative level. It could be billing staff, it could be medical assistants, physicians, any other kind of staff level. And it really should, the representation on this change team should come from anywhere where SBIRT might touch within that site. So it really helps to think about this as a broad team with diverse perspectives, diverse levels of education and expertise. And again, creative, open-minded, flexible problem solvers are the best people to have on this team, and even people who might be a little bit skeptical. So you want those people who might ask a lot of questions and be skeptical, because they're going to really help you think about in detail how this should work. So here's an example of what a champion and a primary care change team would look like. So this is an example from primary care. So in this case, the attending physician was the champion, and this is at a large patient-centered medical home. And we also had the office manager, a medical assistant, the LPN who oversees the medical assistants, and a behavioral health specialist on the team. So this offered a wide variety of perspectives and touched all of the folks at this site who were, that SBIRT would actually affect at the site. The office manager is great for helping you figure out space and any practical issues at the site. And in this case, our physician champion, was someone who had been at the site for over 10 years, really was well respected by her peers, and was really able to get buy-in from staff at all levels. So other just practical tips about Tool 1 is that, it's great to make sure this, whoever you're going to choose a champion, that they really understand what the role of the champion is before they volunteer or are selected. So, what are you looking for? So all the things that I just talked about, making sure that they really understand that that's what's needed. It shouldn't just be someone, stuck in this role just because. Hopefully you'll be able to find somebody who, is somehow passionate about implementing this practice. It's great to provide a quick reference guide for any champions or change team members should they not be knowledgeable about SBIRT or what their roles are. So something that we've done is we put together what we call a mini guide that we can give to a new champion or a new change team member, so that, if anyone asks them, well, what is SBIRT, or, what is this? How does this affect me, or how does this affect the site? They can actually speak to that rather than, not be able to, give details. So, we've put together a little guide for sites so that, or for champions and change team members, so that they really have, what are the basics of SBIRT, what are their roles, what are other staff's roles at the site, any program details that they would need to know. We have frequently asked questions in there, and this has really helped them, people feeling like they understand what they're supposed to be doing. Really having champions at multiple levels. You don't need just one. It's great if you definitely should have one, but depending on what the makeup of the site is, or particularly for large sites, I think it's great to have champions in multiple position types or levels. For example, if you have a large emergency department that has over 100 nursing staff, it's great to have a couple nurses who might work different shifts be champions. And in addition to the nurses, you might want to add a physician champion or an administrative champion to that team. So, it's not limited to just one person. I think you can really build the team for whatever situation is happening at the site. And the change team can really be fluid, so it can change based on needs. So maybe at the beginning you need a certain makeup of team, but then once things get going, it makes sense to add or remove certain members depending on what's needed. So this doesn't have to be something that's set. It can be something that adapts over time. So Sarah, I'll stop there just to make sure there aren't any questions.
Actually, I have 2 questions here.
Okay, great.
How much training will staff need to implement SBIRT?
So that's a great question, and I think it depends on what part of the SBIRT process staff might be doing. We've done different level of training for different staff members. So, for example, if we have staff who are just doing the screening part of SBIRT, we've done brief 1 to 2 hour trainings, sometimes shorter, depending on if we don't get a lot of release time because the site is so busy. So they might just need to know the basics of what SBIRT is, why it's being implemented at the site, and then really have a not a detailed understanding of the rest of the process, but they can have a more basic understanding of the rest of the process, and then really focus on that screening part. So going in detail over the screening questions, doing role plays, and making sure that they're comfortable, especially if this is a new role for them. For people who are doing a brief intervention, you definitely want to make sure that they have enough training so that they feel comfortable. There are different standards in different states. For example, here in New York, in order to bill for Medicaid, some staff, if they're licensed, have to have 4 hours of training to bill Medicaid for SBIRT, while other staff who are not licensed need 12 hours. So there could be state-level training requirements depending on if you're billing or not. So that's something to think about. What I would recommend, particularly if people are doing actually performing the brief intervention, is that they not only have, if they're doing an online training, that's great. There are a lot of really great web-based distance learning programs out there to learn SBIRT, but that they also have a chance to practice and learn those skills in person and receive some additional training. There really aren't any licensure standards out there, but like I said, any level of staff can really do this if they receive the proper training. I think it really sometimes depends on what their experience is and what kind of clinical experience they might have had before.
Okay, great. I just want to remind our audience that they can submit questions to the questions box or the chat pane. And Megan, I just want to make sure that we could provide a link to the mini guide that you shared about following the webinar.
Sure, I can send that to you. Sure.
Okay, great. And then we will share that with all the attendees.
Okay, so moving on to tool number 2. So here's where we really want to get down to the business of understanding what the barriers, and hopefully there are some facilitators too, of implementation. So you really want to conduct an assessment to understand what's going on at this site. In the CASA implementation manual that you will have a link to, we have included a worksheet to do this, so you're welcome to use that, or any other tool that you think would be useful. But some of the factors to think about assessing are patient level factors. So if you need to adapt for age, language or cultural issues, insurance status. So really understanding what the patients are, what the patient populations are, so that you can adjust implementation and make sure you're adapting if you need to. At the staff level, you want to understand what the attitude, skills, training, interest level is. At the site level, understanding what time constraints staff might have, what the staffing levels are and makeup of the staff is, and what kind of training needs that people are going to have depending on how and who is implementing SBIRT. You also want to understand at the organization level, what the level of buy-in is. Do you need to go to some of the higher ups in the organization if this isn't something that they've suggested be implemented? Do you need to go to the organization to ask for resources, whether it be a trainer, whether it be someone to help you think through some of the implementation pieces, or is it that you want to ask for an additional staff person? So making sure that you understand so the resources that you need. Very important is because of the referral to treatment piece of this model, you need to make sure that you have referral sources where you can link patients or clients to if you don't have them in-house. Some places have integrated care and they can cover this in-house, so if that's the case, even better. Electronic medical records. So this can really help or hamper you. Understanding what the electronic medical record is, whether you might be able to add SBIRT into that, and particularly if you're thinking about billing, what you might need to add in to document what you need to for billing, and then how you can collect and manage data. So all these really important things need to be understood before you think about even implementing the practice. And really the goal for this tool number 2 is to determine what the barriers that most need addressing are. So you might have a lot of barriers, but I think really understanding which are the most important you can address, that you can address in implementation, and some might be things that you can address along the way, but at least understanding what those are so that you're not surprised once you start implementing. You can address some barriers via training, some via resource allocation, and some via model adaptation. So there might be different ways that you can address these things. You want to really utilize your change team members to gather the information that you need to assess your barriers and facilitators, and this is a great reason to have that diverse change team. You should, go thoroughly through what some of these barriers might be. You might conduct some sort of needs assessment or a survey or interviews just so you're thorough. Again, we have a worksheet that you're welcome to use in the CASA implementation manual, or you might have other ideas and or examples from other processes that you've implemented. In order to implement SBIRT, you really should know the site. And you might be thinking, well, that the champion should know the site if they're working there, or the change team member should really understand it. The interesting thing that we found is that every person who works in that site has a different perspective and a different experience, and they may not understand what the patient or client does before they get to them or after. And so another reason to have a diverse change team, but also there are some other activities that you could do to make sure you understand the full patient experience and really think about the workflow. So you want to understand the current workflow. You can get some of this information from change team, or you could do an additional activity, for example, shadowing a key staff member. So you might shadow a physician or a nurse, or somebody who is going to be dealing with a lot of patient interaction, so you can understand the patient experience. You might observe the site, or you might conduct a walkthrough actually as a patient. And this is really helpful in understanding from beginning to end, what does the patient visit look like. Once you really feel like you understand the current workflow and understand all of the processes and steps that the patient goes through as they work through that visit, you can then begin to visualize the workflow as it currently stands without SBIRT. So by what we call process mapping, and I'll show you an example of this, this allows you to actually graphically display and visualize what the current workflow looks like without SBIRT. And that really fosters discussion about, okay, well, where can SBIRT or the different pieces of SBIRT fit in to our current workflow? And then you can work on creating additional process maps with the SBIRT components plugged in. There's some great software out there that can help you do this. We often use Visio, which is a Microsoft product, but there are others out there that can actually really help you quickly put together these process maps. Here's an example of what a process map might look like. Again, in the CASA implementation manual, we have some examples of this and some guidance on how to put these together. So this really starts with the patient seeing the receptionist at the top, the receptionist determining whether the patient needs a brief screen, and that happening. So the process steps where the patient gets the screen, it's collected from the patient and then reviewed, and then working through the rest of the process. Does the patient need a brief intervention? Does that brief intervention happen? Is there time for the patient to be seen? And at the end, the patient meets with Sue, the person who provides the brief intervention. So obviously, this is going to look very different for whatever the workflow is for your specific site, and where you choose to implement the SBIRT pieces and how you choose to implement this. So in this example, there's a pre-screen that's done, and it's done by the patient in a waiting room. Another model might have a nurse or a medical assistant doing that pre-screen. So there are a lot of different ways to do this, and I keep repeating that because I think it's really important to think about. You don't have to box yourself in to one way of doing the practice of SBIRT. So just some tips related to this tool is, to really try to use objective methods to determine the workflow so that you don't overlook important factors like the shadowing or walkthrough or observation. Again, a lot of people come with different perspectives and think they understand the total workflow, and we've found that that's really not the case all the time. And then really try to think about putting all options on the table and thinking about how and where to build in those SBIRT components. You might think that you can't ask a nurse or a medical assistant to do screening, or that patients won't answer the questions in the waiting room. But unless you put that to the test, then you really don't know if it's going to work or not. So definitely think about different ways to do this. So once you're ready to think about trying out some of the new workflow that you've put together for the SBIRT process, then you can do something called the Plan, Do, Study Act cycle. The Plan, Do, Study Act cycle is taken from the quality improvement literature. This is something, while people might not call it a PDSA or Plan, Do, Study Act, people in healthcare, behavioral healthcare settings, this is something that they understand and that they actually often do for quality improvement. So this is not a foreign practice in healthcare settings. So, this is something that has worked well to help us address any issues that we've needed to address during implementation or after implementation if we've run into issues. So really what this is a mini experiment to test whatever the new SBIRT process is that you've come up with to implement into the workflow for the first time, or any changes that you want to make to the existing process. So maybe something's not working. Maybe it worked in the beginning and there have been changes at the site, and you now want to test out some changes. This is something that's conducted quickly over a short period of time and helps you determine whether what you came up with works or if you need to come up with something new and do another cycle. So the plan, you're really defining what the objective is. What are your questions? What do you want to try out? And also planning how you're going to collect data to figure out if it worked. The do part of this is carrying out the plan and then collecting the data that you plan to collect. Study, you take a look at, what did you find? What does the data look like? And then act is, do you need to plan another cycle? Maybe this didn't work, how you hoped it would work. Maybe you need to make some tweaks. Or, is this something that's worked out well and you want to keep? And then how do you make this part of your normal practice? So here's an example of a PDSA cycle that we tried when we were implementing in an FQHC. And it's a very busy site, and we wanted to just try out one small piece of this, which was, can we even get the LPNs who conducted vital signs with patients when they came in to do an audit C, so a pre-screen for alcohol use? Would this be something that worked? So we, as part of the plan, decided that one LPN who was really bought in to this needing, she was very interested in making sure that patients were screened. She felt like it was an unaddressed issue, so someone who is a great champion. She would screen patients using the Audit C on Saturdays for 1 month. Saturdays were a slower day for this particular practice, and so we decided that that would be a good way to try this out. It's not being done on a very busy day, and she can really see if this works. So the do part of this, we had the LPN conduct a screening every Saturday for a month, and in this particular practice, the audit C was programmed into the electronic medical record, as well as a documentation piece for her to record, to actually click a button that says, to record the screening and the score. The study part of this was examining that electronic medical record data. And we found that she was able to get about 80% of the patients during the time frame that she was allotted to do this. We also conducted an interview with her to get her experiences and to really understand from her perspective how feasible it was, how this felt being added to her workflow, how she felt her peers would feel about it being added, and how the patients reacted. And based on our discussion with her, things looked great. She felt it was feasible, didn't add much time. The audit C is 3 questions, so it was something that she felt she could do, and most patients did not react poorly to it. So as part of the act, this was decided that screening would be expanded to the additional LPNs, and then another cycle would be conducted to see how that went. So this, you can see, is something that's very short. You're not trying to implement necessarily the full practice, but this can tell you about how one piece would work. So this is starting the process new. Let's say you've already implemented SBIRT, and you're seeing that there's something going on that it's not going as well as you hoped it would. So we had in one of the sites that we've worked with, we saw that patients, were based on the patient census, the rate of the pre-screen for SBIRT being completed among those was, according to what we thought, pretty low. So only about 60% of patients were being pre-screened. So we talked with some people at the site and thought, okay, what's going on here? And what we found out after talking to some medical assistants was that they were the ones who we originally trained to do the pre-screen. We thought, based on our initial work, that they were the only ones that actually would take the patient back to the room and do vital signs. So that was the general workflow of the practice. So we focused on them for training and implementing the pre-screen process. What we found out was that actually there was another side process where this was a resident practice, and some residents were actually bringing patients to the rooms themselves and kind of skipping the medical assistant, doing vitals, and then they weren't trained to do the pre-screen. So they didn't know that they should do it, and they didn't know how to do it. And so what we thought was, well, can we train the residents to increase this pre-screen completion rate? So what we did was have the champion of that site train that group of residents to conduct pre-screens. We, as the do part of the model, we had them conduct pre-screens, and then took a look at some data. We already had a data collection process that we had at the site because this was an ongoing model, so we were able to take a look at the pre-screen rate. And then we examined it. We saw that it actually increased by about 20%, which made us pretty happy. And we thought that was a big enough improvement, and that we would continue training residents. In this particular practice, groups of residents come and go, and so there's now an ongoing process in place that every time a new resident group comes in, that resident group gets trained in conducting these pre-screens and the basics of SBIRT when they start their rotation. So just, some basic tips. Keep them short. It doesn't make sense to implement a change and keep it going for weeks and weeks and months unless you know it works. So really keeping it short and keeping it small. So, as in these past 2 examples, you can see this is a very small piece of the process that we were talking about here, and you can do that with different parts of the SBIRT process. Not discounting ideas that may not at first sound feasible. Seeking feedback from frontline staff, you're going to learn a lot, even if they're not part of the the SBIRT process. Maybe they don't do one of the SBIRT pieces. Getting some, feedback from people at all levels, making sure that you're really dialed into how people are perceiving the process actually is very helpful. And then carefully planning for data collection. So you're not going to be successful at a PDSA cycle unless you can really collect the correct data so that you know if it's working. Sarah, I'll stop there again. Any questions?
Yes, we've just had one question come in.
Okay.
Do you ever get pushback from providers to collect the data necessary for PDSA cycle? And if so, how do you handle that?
So yeah, so that's a great question. I think that if you can automate the process in any way, that's the best way to sort of handle that. So for example, if you can use the electronic medical record, for example, if SBIRT is in, if you're able to document in the electronic medical record and actually access that data, we found that in the first example, that was the best way to look at how things went, and that actually did not add burden to anybody. If you can't do that, then you definitely, you need buy-in from the staff, and I think that's an important part of the process. But I would say any way you can automate that or use processes that are already in place is really important. So for example, in a lot of our sites, we want to understand the patient census. We want to know how many patients walked in that day so that we can see how many of those patients were screened. And so we worked closely with the people that record that in each site and try to automate the process of getting that information so that somebody doesn't have to tally that every day. In some cases, we've had to do that, but again, thinking about automating it and using systems that are already in place, I think, is really important.
Okay, I have two more questions here. This one goes back to SBIRT training and education.
Okay.
Do you have any web-based SBIRT trainings that you would recommend?
So there are a couple, I think there are a lot of trainings out there now. If people are in New York State, we actually created a training specifically for New York State practitioners. So that would be, something specific to New York State practitioners. I think it really depends on what the needs of people are, again, so going back to what part of the process people are doing. There are a lot of different training programs out there, and I don't think I would recommend one over the other, but I would say that if you're selecting a training online, that to make sure that it includes a lot of examples and opportunities to check your skills. So it's not something that just sort of you're reading something and that's it. So I would just suggest if you're selecting something that it's as interactive as possible, and there are a lot of great ones out there, and that give you an opportunity to check your skills. I would say there's one thing that we use with our health educator staff after we actually do in-person training, which is a NIDA. It was funded by NIDA, and it's available for free, and it actually is kind of a simulation for people to practice their brief intervention and motivational interviewing skills. So that's something that I would suggest is sort of an add-on once people have done some initial training, but any training that's going to have an interactive component.
Okay, and we'll take one more question here. Can you recommend any specific organizational readiness assessment or workflow analysis tools?
I could certainly send some, Sarah, to you that are out there, sure. And then you can share it. Yep.
Yeah, we can share that with all of the attendees.
Okay, great. Okay. But again, the cost implementation manual, while it's not a traditional needs assessment, it is sort of a checklist document that you can utilize as well. Okay, and so turning to tool number 5, so my most favorite part is data collection, and so this is one that is very exciting to me in that you really want to use data to monitor your program performance and progress and understand how implementation is going. And so, I've mentioned this already, I'll mention it again, understanding, how you're going to collect that data, what metrics you're going to use, how you're going to manage it, analyze it, and how and at what frequency the results are communicated, and really to who you're going to communicate those. So it doesn't really make sense if you're collecting data and you don't have a plan as to who's going to look at it and how you're going to use it. The data can really help you to drive decisions and inform when a PDSA cycle is needed. So in the PDSA example I gave, we used the data that we collected to see that the pre-screen, only 60% of pre-screens were being completed, and that told us, hey, I think we need to come up with a PDSA cycle here and see if we can improve that at all. So it'll really tell you not only how well you've implemented, but also how well the practice is enduring at the site. Here's some examples of things that people may want to think about including. Understanding the total patients eligible to be screened, so whether it's the patient census, or if you're only doing screening once per year, understanding which patients that day need to be screened, how many patients received a screen of those eligible, how many patients were positive, how many patients were eligible to receive a brief intervention if they were positive, and how many patients were eligible and received and actually received a brief intervention. And then, if you've built some kind of follow-up into your program, not everybody does that, but understanding if you followed up with patients if they needed it. So, the data does not have to be complicated. It could be just frequencies of how often things are being done, and that helps you create sort of the percentages to understand how things are going. So this is an example from our SBIRT, New York SBIRT project with Northwell and the New York State Office of Alcoholism and Substance Abuse Treatment. This is something, we put a chart, a flow chart together like this every single month. We do it for our whole project, and we do it for all the individual sites that we're working in, so that we really understand every piece of the process and where things could be improved. This changes from month to month, and so as we do different improvement cycles or as things are changing at the site. So, for example, we had a site that had an EMR change that changed the workflow quite a bit and affected how many pre-screens were being completed because the workflow changed and we hadn't adapted to it yet. So, the data that you can collect can really help you put together charts like this, or it doesn't have to be exactly like this, but helps you really identify where improvements are needed, and should be done regularly because it does change. So besides kind of putting together just a basic flow chart, or at least understanding the different metrics that you choose, you can do some other things to understand how things are going. And so some things that we've done have been to do basic surveys of site staff, to understand their attitudes about the program after it's been implemented, people's behaviors, so how are they actually, or are they actually conducting SBIRT as it was meant to be, their favorability toward implementation of the practice. So just basic surveys. I think we try to keep it short, 15 items, sometimes less, to really understand how things are going. We've also gone and done interviews with site staff to get a more in-depth understanding of how people are feeling about SBIRT and how it's been implemented at their site. We've done this with physicians, with nurses, with health educators, to really understand in detail and put context to the surveys that we conducted. So I'll share some results. Again, this is part of the New York SBIRT project with Northwell. So here are a few questions we asked. How supportive they were of systematic screening, whether they believed substance misuse was a problem, whether they believe substance misuse impacts health. So we were trying to really understand if there were attitudes among staff that were conducive to SBIRT being conducted and maintained, or if we needed to do some more training to make sure people understood the value of screening and that it really did impact health. And so you can see, we were pretty happy with what we saw here. The darker lines are medical assistants and RNs. The lighter lines are physicians from the sites. And so you can see that about 80% to 100% either agreed or strongly agreed that they supported systematic screening, they believe substance misuse was a problem, and that it impacted health. So, that indicates that there are supportive attitudes about, actually doing SBIRT at the site. We also asked them about some very important things, which had to do with whether they thought workflow was disrupted, whether they thought that SBIRT had increased patient wait times, and whether they were overall favorable to the implementation at their site. So again, we thought this was mostly good news, and that less than 10% of the staff agreed or strongly agreed that implementation of SBIRT had disrupted their workflow. So that's great. About 10% of MDs felt that it did not agree that it affected their patient wait time. So again, patient wait times are very important for a lot of different sites, and so they don't want to increase that. So we felt like that was a good sign that we hadn't increased wait times for patients by implementing this. And that overall about 70% of the RN and MA staff agreed that they were favorable towards implementation, and about 85% of the physicians. So, some work to do there, but overall the majority of people were favorable. So doing surveys like this can really help you understand how things are going at the sites that you're implementing SBIRT in. Yeah, I told you that we also did some interviews, so these can really give context to what you're learning in surveys. Or if you don't do a survey, they can still give you great information. So here are just some quotes that I pulled from our evaluation. And we learned that for a nurse who is in the emergency medicine site, she wished there was a way to see how they're actually helping people. So she was interested in learning more about what happened to the patient after they left. And so this sort of made us think, and we heard similar things from other staff. This made us think about how we can share the results of the program with staff and how we can follow up with patients so that we can feed back to staff how patients are doing. This indicates to us that to maintain support for the program from staff like RNs in an emergency department, that we really need to make sure that they understand how it's helping patients so that they do the extra work that's required to actually do SBIRT. The bottom quote here is from an internal medicine physician. Indicates that in the beginning this person was very worried about implementing this and the workflows, but over time he or she actually now sees the value. So this indicates to us that things are going pretty well for this person. So we've talked about a lot of tools up to this point, given a lot of examples and tips, and so thinking about how this all comes together. So this is just, if you're a visual person, this kind of puts all of these pieces together, in that you really want to work with the champions and change teams to get started, put together a flexible and enthusiastic team if you can. Use some of those tailored implementation practices that we talked about, so understanding the workflow, understanding the sites, assessing your barriers, and then when you're ready to go and you think you understand the site, you've got your team, really utilize some of these rapid change PDSA cycles, and then make sure that you've got that performance monitoring data ready to go. And this is a cycle that can continue depending on how well the sites are maintaining the practice. Any questions, Sarah, before I continue?
Yep, we have a couple in here.
Okay.
Are there any particular screening tools that you prefer?
I think it depends what you're screening for, and so the audit is something that's widely used. The assist is something that covers both alcohol and drugs, but if you know the assist, you know that can be a pretty long tool, and so that's something that works really well if you can actually program it into a computer-based program to help you do that screening, because it can help you skip through that tool. So I think the audit and the assist work pretty well. We use the DAST as well. That has some advantages and disadvantages. It's a very quick tool, but you don't learn a lot about the frequency of substance use using that tool, and you don't learn a lot about what substances people are actually using. So I think it really depends on what you're hoping to screen for, what your population is. You might need to use a different tool if you have an adolescent population, for example, or if you have an older adult population, there are specific tools for that as well.
Okay, great. We have quite a few questions coming in, so why don't we take one more now and then the rest at the end.
Okay, great.
So have you ever tried doing focus groups with staff to get their feedback?
We would love to do focus groups. I think we actually ended up doing interviews instead, because we found that, so we did individual interviews rather than focus groups, and in most cases because we found it really hard to get the staff that we needed all in one place at one time. So doing individual interviews, you can be a lot more flexible. You can, if it's a nurse working in a busy emergency department, you can wait until they're ready rather than trying to set a time for 5 nurses or 5 physicians to show up at the same time. So I think it's worked better for us just to be careful of people's time and flexibility to do individual interviews, but focus groups are great if you can get everybody in the same place at the same time.
Okay, great. Well, we can take the rest of the questions at the end here, and if there are any questions that we don't have time to address, Megan will answer them after the webinar, and then we'll share those responses with all the attendees.
Okay, so, and thanks for your questions. So I think, one thing to think about is, you can celebrate, let's say you've implemented SBIRT, everything's gone great, and it's going. It's working. Your work really isn't done there. So you can certainly celebrate, but then make sure that you go back to the business of monitoring what ongoing needs there are. I think, we were so relieved when we got the practice started, in our sites. Things seem to be going well, but what we learned very quickly is that if you don't continue to look at the data, you don't continue to talk to people via evaluation, you don't continue to build champions and think about what ongoing training needs there are, then I think things can start to go awry pretty quickly. So really think about this as an ongoing process rather than you've implemented and you're done. I think really to maintain a sustainable practice, it needs to be monitored and continue to build resources and training and champion building if you can. And I think this is true for any new practice. So this is not something specific to SBIRT, and many of the tools that we've talked about today can apply to any new practice that you're trying to implement in any site. So a few other practical considerations. Training, as we've talked about, it's a necessary thing, but much more is needed than training. So I think a lot of people that we've seen, sort of out there make the, I guess, the mistake that sending staff to training is enough. So staff are trained, now they're gonna do SBIRT. But I think you've seen all of the other things that need to be thought about as you're implementing and maintaining SBIRT. And so really putting all these other things in place is a very important thing. I mean, training is absolutely necessary. Again, it varies on who's going to be doing what, but thinking about all these other things. Technology can really be helpful or can be a hindrance, as we found. So electronic medical records start very early in the process if you're considering using putting any SBIRT components in the electronic medical record. We found it can take months, sometimes a year, to actually implement changes because of all the clearances that need to be done as part of changing anything in an electronic medical record. It can really help the process because if you program in some of the questions that you're asking, if you program in places to document when a service was completed, that's going to help you greatly, because staff have everything right at their fingertips. But if it's not in the right place in the EMR, it's not accessible, it's not easy to use, or it's not there at all, then that's not going to help. There are other technologies being developed out there. People are creating tablets, web-based tools. Those are all great things to think about as well, and that can really help take the burden off an actual person. So if you can, utilize a tablet or a web-based system to do some of the screening or even some of the feedback as part of a brief intervention, I think that can really help things as well. And I think we'll start to see a lot more tools coming out that can help with that. Really thinking about what the site is, the patient population, staff differences, patient differences. Even if you're implementing in 4 primary care practices in the same organization, those practices are going to be different. And so not trying to go in and implement the same thing, even if you're working in the same organization, I think is important to think about. There are a lot of different models of SBIRT out there, so it can be a health educator, or I guess this, you can think about that as this is like a added single staff member doing all the work, or you can think about it as team-based. It's really going to depend on what the resources and setup of that site is. Billing and reimbursement we've already talked about, so lots of things to think about if you're thinking about billing, but really making sure that you, if you're thinking about billing and reimbursement, working with your administrative staff who deal with billing to get all of the pieces in place. We found that that actually can take months depending on what back-end systems need to be put in place in your organization. The other thing is, this process is not quick necessarily. So we found that generally the time needed to roll out in a site can be about 4 to 6 months, when you're going through all of these processes. So going from gauging leadership interest to working on the workflow and logistics, EMR changes, training of staff, and then doing your PDSA pilots, and then going live. I mean, this could really take 4 to 6 months, depending on how quickly you can get some of this done. So think about this again as sort of a process rather than something that's just going to happen quickly one day. I want to now introduce my colleague, Dr. Sandeep Kapoor. He is going to tell us his top 5 considerations for implementing SBIRT. He is currently the director of SBIRT at Northwell Health, as well as an assistant professor of medicine at Hofstra, Northwell School of Medicine. And we've worked very closely together over the past 3 years on the New York SBIRT project at Northwell Health in implementing. And we've now implemented in 4 emergency departments, and I believe it's 4 primary care practices, 5 primary care practices at this point. So I'm happy to have him join us to give us some tips from his perspective as well. So Dr. Kapoor.
Hey, thank you, Megan, and thanks for everyone for joining, and thanks for IRETA for setting this up. I think hopefully everyone has a slide in front of them, and I hope this just emphasizes the points that Dr. O'Grady has laid out so very well during this webinar. But over the past 2.5 years working in a collaborative fashion, we've been successful in implementing SBIRT in a multitude of sites, both in primary care and emergency medicine. And on top of that, we've been fortunate enough to share our lessons learned with folks that are newly thinking about implementing SBIRT or refining their processes that they have in place. Megan had asked me to put together 5 considerations to keep in mind when implementing SBIRT. So roughly, we came up with these 5, and I just want to highlight a few of them in a bit more detail than the others. But I think the first and foremost thing, and just to reemphasize and echo the words of Dr. O'Grady, it's very important to make this a team-based effort, and not just a team-based effort when thinking about providing services, so who does the screening, who does the brief intervention, and so on, but really it should be a team-based approach for planning, implementing, providing the services, and maintaining and sustaining the service. So really trying to figure out who you want to include in that change team that Megan spoke about, but really allowing folks to feel ownership and accountability for the initiative goes very far. And one of the questions that was raised about the focus group, we didn't hold direct focus groups per se, but we did elicit feedback from every single person that we touched, every single person we trained. Every time we went back to do a refresher, we actually framed it as a feedback session and not a refresher, because we wanted to give folks the voice that they deserve in letting us understand what was working, what wasn't working, and how do we move forward. Understanding the site workflows, very important, and Megan had mentioned about doing walkthroughs, really trying to see as a patient or a client the different people that they interact with, what questions are asked, if there's redundancy. This is key, and again, it goes back to having a team-based approach, because when you do have a interprofessional, interdisciplinary cohort of folks that are involved with planning and implementing, you can get a better understanding of really how this is going to work in existing clinical workflows. Site workflows, I should actually have written site workarounds as well, because workflows are one thing, but there's multiple workarounds, and as Megan had mentioned, we had seen an issue with our pre-screening rate and very soon learned that our residents were rooming patients bypassing the MAs. So there are workarounds in place. So it's not only about identifying and understanding workflows, but it's also doing your best to understand workarounds and create your own workarounds to make sure that this process is viable. EHR, so electronic health records, or EMR, electronic medical record changes, are vital, especially if your site or sites are currently using electronic medical charts. This not only helps to integrate within workflows, it also helps to aid in service delivery. So not only can the screening tool or tools be inserted into the electronic medical record, but also notation, documentation, so that other members of the clinical team understand what happened during that interaction, or even as simple that an interaction actually happened. And then performance monitoring, having detailed reports pulled out of your electronic medical records really help in the process of feedbacking to the site, to the folks on the site. So letting them know what kind of numbers we're looking at when we're talking about how many patients were screened, how many received a brief intervention, how many were missed. This is all a process of feedbacking to the folks, so that to the frontline folks, so that they can fine-tune workflows, or you can help fine-tune workflows via PDSA cycles. So really, EMR changes, they do take a long time, but if your sites are on an electronic medium, it is well worth starting that conversation sooner rather than later, so that you can get the process in an automated fashion. I must say, though, as Megan mentioned, we did go through some electronic medical record changes, system changes within a single site, or we had delays in actually getting SBIRT implemented in the EHR, and paper works very well as well. So we created a workaround where certain clinical team members, the medical office assistants in our primary care practices, were actually screening on paper and handing that off to the next level of service, or the next clinical team member, which was our health coach. Training, can't emphasize this enough, and I think training may be the wrong word. It should really be raising awareness. We believe in training everybody and anybody that we can get our hands on. So it should, training should include not only the folks providing the service, may it just be doing the 3 to 5 question pre-screen or providing the brief intervention, but folks that are also part of that overall clinical team. So if docs want to get trained up, nurses, the administrative staff, because they're really the ones that are enforcing workflows or performance markers within clinical settings. So we invite everybody to the initial training, and then really put a huge effort into ongoing training. And that's when the champions and the team-based approach comes into play, because then you have multiple members of your team that can really inform and continue to elevate or raise awareness of clinical team members by providing refreshers or just having feedback sessions with them. So training is not just a one-off thing. It needs to be initial and then consistently ongoing. And then lastly, I'll just conclude with our success really has been driven by the fact that we have put time and effort and strategies towards engaging our clinicians, our clinical staff members, our administrators, even our own SBIRT team members, making sure that we create avenues of two-way communication so that we can feed back information to them and really open up that avenue to listen to their feedback, take that, understand it, and try to implement changes based on that feedback, and then going back and thanking them. So really engagement is key. Even once it's implemented, to sustain and maintain, you need to consistently engage folks, and that's really where we've seen our success. Thanks.
Thank you so much, Sandeep. And I just wanted to highlight that there are, so I've put here the link to the CASA implementation manual, so we hope that's helpful for people. There are other implementation guides or manuals out there, so I've included the CDC has one for primary care. SAMHSA has a systems level implementation manual out there. I've included a link to the New York State SBIRT page, as well as a link to a video that we've created to get healthcare staff interested in SBIRT. So I just want to thank everybody again for joining. Thanks everybody for the questions that they've asked. Thank you to Dr. Kapoor for joining us and giving his experience, and thanks to IRETA for having me.
Thank you so much, Megan. Can we take maybe one or two questions, and then I'll go over the CEU and evaluation information?
Sounds good.
Okay. So our first question is, can you refer to an emergency department that currently does SBIRT?
Yeah, so as part of our New York project, we've got 4 emergency departments. My contact information is here, and if you're interested in learning what that emergency department is, then we'd be happy to share some information.
Okay, and we can certainly connect this particular participant with you after the webinar for more follow-up.
Sure.
The next question here is, population data suggests that about 20% would be positive for a problem or a substance use disorder. The New York SBIRT pre-screen results in 11%. Are possible positives being missed, or is there something else going on with the data?
This is a great question. It's something we've thought about a lot and talked about a lot. So we too, when we started here, this project and in other projects that I've worked on, we see a much lower positive rate, and I think there are a couple things that we think is going on. In this particular project, the nurses and medical assistants, depending on what kind of site it is, do the pre-screen. And so, there potentially could be fidelity issues in how they're asking the questions or recording the answers. So that's one potential issue. The other is that this is a combination of different site types, and so that the screen that you saw was included primary care and emergency practices. Within, if we look at the individual sites, we actually see a pretty broad range in what those pre-screen positive rates are. For example, in the emergency departments, we see closer to that 20-30% range, while in a small primary care practice, for example, that has an elderly population, we see a very low pre-screen positive rate. So I think it really varies based on who your patient population is and how you're implementing the pre-screen or the screening.
Okay, great. Well, thank you so much, Megan. I think that's going to be our last question for today. We do have a few questions that have come in still, and again, I will share them with Megan and have her answers disseminated to all of the attendees.
Great.
So I just want to thank everyone for their great participation and great questions. At this time, I'd like to go over a couple of CEU and evaluation pieces. So Megan, I'm just going to go ahead and take that screen back from you. So following the webinar, you're going to get a few emails from us with links to the recording as well as a PDF version of today's slides. Those slides are also available for download in the handout section of the GoToWebinar toolbar. Included in the email will be a link to our evaluation. Our grant evaluators are required and pleased to collect feedback from all event participants. Completion of this evaluation is critical to maintain our funding and continuing to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. Immediately following the evaluation is a request form for a certificate of attendance or a NADAC or PA-CADC CEU. Today's webinar is approved for 1.5 PA-CADC continuing education credits and 1.5 NADAC continuing education credits. Once you have completed your request, it will direct you to a purchasing page, following which you can download your certificates from your My IRETA profile under the CEUs and Certificates of Completion section. If you have any questions, you can feel free to contact us at info@ireta.org, and we'll be happy to get you your certificates. Again, we want to thank everyone for their participation today. And again, if you have any additional questions that you didn't get to ask on today's webinar, feel free to send us those questions in an email, and we will share them with Megan. Okay, thank you very much, everyone.